Let's look at some stats. 8.5 crore Indians suffer from mental health issues. Out of these 8.5 crores, at least 5 crore Indians suffer from depression and 3 crores from anxiety-related issues like panic attacks and PTSD, which is post-traumatic stress disorder. That is approximately 6.5% of the entire Indian population of 135 crores. That's a lot of people, and these are just the reported cases. Now let's tell you about how many of these people actually seek help. Did you know 70 to 90% of people actually don't reach out for help? 70 to 90%. And why? Because for every 10 lakh Indians, there are only 3 psychiatrists and less than 1 psychologist. That is something to be shocked about. We're talking about depression. Let's talk depression. It's an illness. It's not something that you feel. It is something that you have.
No, absolutely. In fact, the fundamental problem, and sometimes I actually feel that if depression were called something else, which did not have a direct English meaning, then probably this confusion wouldn't have been there. Because in your normal day-to-day conversations, you might say, oh, I was having a bad day, I was feeling low. I was having a day where I was depressed. And your normal response would be something on the lines of, oh, get yourself out, go take a walk, go with your friends. And that's the normal connotation that we attach when anybody we feel is not having the best day. Now from there, the same word depressed is also used clinically in terms of an illness by people like me. So when I say that I am depressed, I here mean that I am having a certain illness, like a typhoid, like a diabetes, like a hypertension, like a dengue, so on and so forth. So, and I will not then say, oh, pull yourself out of it. I'll say, well, get a diagnosis done. Let's look at whether medical treatment is to be done or not. Let's look at whether therapy needs to be done or not, because this is how you treat a particular illness. So depression is not a matter of choice. If you were to have depression or if I were to have depression, we will get it. I cannot do something to prevent it.
And we don't choose it.
And I don't choose it. I may be a 8-year-old, 10-year-old child. I may be a working adult. I may be a parent. I may be a 70-year-old man. Either ways, depression can happen, and be very clear. Depression is the single largest illness in the world as per what WHO says. 300 million people globally, which basically means that if you are going in a metro, there are more depressed people who have a clinical problem, a disease, which is like any other disease that they are suffering from, and it's that prevalent.
I love that you said depression is like typhoid. You've got to fix it. You've got to take medication for it. There seems to be this, almost perception that medicine is bad for you. But which is why I want you to explain the chemical imbalance that happens when you are depressed.
So I'll answer all of these points because these are very valid things that you've said. Yes, it's an illness. And yes, it has a treatment protocol which is evidence-based. So for example, let's say if you have typhoid, then there is an evidence-based treatment that if you will be given this antibiotic, something for pain, something for fever, the antibiotic will be given for X number of days. If this one doesn't work, then you add this one. And there is a criteria, there is a guideline. Similarly, depression has guidelines and evidence. All people do not require medications. Some people require medications without any doubt. Some people require only psychotherapy, or more conventionally called as counseling. Some people require a combination, which is predominant people who require pharmacotherapy, which is medications, and psychotherapy, which is counseling put together. And there is a way to go about it. This is not random.
Right.
This is not personal discretion. This is very much an evidence-based treatment. So if one has depression, then one needs to go. Now the question is why this whole thing about medications is there. So try and look at history. Look at when did the first official medication for any psychiatry problem came in the world. We're looking at 50s. Obviously, initially when the medications were coming in, they had their own side effects. Some had more sedation, some had some other side effects. Then, another 10, 20 years went by. In between, electroconvulsive therapy had also come up. Then you had fluoxetine that came. The SSRIs started coming somewhere in the middle years. Then towards 90s, you had a lot more medications coming in. Now you have medications which are a lot more selective, effective, potency is good, side effect profile is good. But we've virtually had 60, 70 years where you would have thought that if you take a psychiatric medication, you'll take it lifelong. If you take a medication, it will make a vegetable out of you. That you will probably get addicted to it. That's only about sedation. Even today I am asked by people, the other day I saw this 28-year-old woman who's a working person, drives to work. We've diagnosed as depression, prescribed medications. And her question is, but doc, will it just keep me groggy? Will my colleagues realize looking at me that I'm taking medications? Will it make me slow? Will it affect my brain negatively? Will I be addicted? Will it be lifelong? Will I be able to drive? Now these questions are valid questions.
Yes.
But these questions are also based on years of myths that have been floating around in the society that we ask this. You would have not asked these questions to a physician who would have given you, let's say, treatment for hypertension.
But the good thing is people are asking questions,
Yes,
and that's important.
absolutely. In fact, conversations is the only way to fight stigma.
Absolutely right.
You can't fight stigma by sitting at your home and browsing the net. You fight stigma by talking about it. When you hear people speak and you realize so many people think similar, and at the same time you realize so many people are now thinking differently, and when you share your experiences, that's what makes a difference. I mean, I have been now in practice for over 17, 18 odd years. Add my years of education, then over 20 years in the field. Have done scores and scores of talks and articles and lectures to make an impact that people realize, and you break the myths. But one role model who's followed by several people, whether the person is from film or sports, and that one person saying that, listen, I had depression, I was okay taking meds, I took counseling, it's helped me so much. That is way more than hundreds of people like me doing what we are doing, because that's what hits stigma.
Yes.
And that's what breaks the whole walls around stigma.
In fact, Deepika Padukone coming out openly and talking about it impacted a lot of people.
And since you are mentioning her, so let me give you an example of this. One expression of this role model who's looked up by people across the ages, especially by a lot of young women, what it did was, it normalized the aspect and the illness of depression. That, well, if my role model can have it, if my role model can decide to take treatment, so can I. I don't need to now hide, I don't need to be hesitant. And more importantly, my role model struggled and came out of it and continues to blossom.
Absolutely.
So, and this is the kind of advocacy that makes an impact. And that's why if you want stigma to go, you talk about it.
Like you said, depression is like typhoid. You can't run away from it. You have to treat it. Depression is the best kept secret in every household in India. Somebody or the other is suffering from it.
I think it's very well put. It's not possible that anybody who's listening to this does not know someone who's suffering from depression. It's not possible. And if you don't know, then you've missed it out. Because statistically, it is not possible. If you are meeting more than 10 people, 15 people in a day, well, you just missed out a person who was depressed.
8.5 crore people in India, and these are just the reported figures. We don't know so many of them. Anyway, I'm coming back to what we started talking about but didn't complete, is the chemical changes that happen in the brain itself. Tell us, as a psychiatrist, explain to us, cut it down as simple as possible for us.
So see it like this. See, 3 categories here. The biological category, as in causative factor, the psychological factors, the social factors. In our terms, as in how we talk to young students coming in the field, that it's a biopsychosocial model. Most people have heard about it. Biopsychosocial model. Now, out of these 3, bio is not in my control. So bio means the biological factors. These would include some genetic factors. So let's say I had some genes, the genes are making me secrete some neurotransmitters more or less, some hormones more or less, and it's making me more predisposed, something on those lines. Then there are neurotransmitters, popularly called as brain chemicals. Right?
Dopamine,
serotonin, norepinephrine, epinephrine, glutamate, so on and so forth. There are lots of them. Let's not be preoccupied with what that name is, right? Or what that neurotransmitter is called. In fact, the famous Munna Bhai, where they talked about chemical locha. And I'm telling you that probably one of the most unique ways of making such a clear bit of medical science so palatable to human beings, it's a chemical locha, right? And which is very intriguing, because this is the kind of narrative that is required to make more and more people understand, rather than giving them nice big chemical diagrams and saying, oh, this is so complex. It's not. So that's the biological factor. So what is happening here is, let's say I have a 30-year-old man who is predisposed, maybe some genetic factors, and is having low levels of a certain chemical. That chemical is now giving this individual symptoms which may be of depression. So that is, and now this chemical is not in this man's control. His diet, his exercise routine, his personality and all are not going to change this, because this is how it is. Now the second component is the psychological component, your thought process, your personality, your early experiences, the way you think, the way you interact, your interface with life, which are your own personality components, your cognition. So for example, when you do now treatment of depression, so this 30-year-old man might have been given a tablet to take care of the chemical imbalance, would have been given psychotherapy to take care of the psychological factors, like let's say negative thought processes, cognitive errors, where he might be feeling more negative about things, more hopelessness, a lack of self-esteem, so you work upon that. And the third component is the social factors, which is your environment. So environment may give triggers, your support systems, your interface with the social. So it is these 3 aspects which bring about an illness. And the other thing one needs to understand, which this is how the illness is caused, which is also important to understand, that what is manifestation of the illness. So before you try and understand what the symptoms are, you need to understand why an illness or when an illness becomes an illness, and that's the impairment of functionality or functional impairment. So let's say I'm a 16-year-old boy and I had a bad exam result today and I am feeling low. I don't feel like talking to my friends today. I'm feeling a bit disappointed. 3-4 days go like that. 4th day my parents take me out. I start feeling a bit better. They make my friends come over. We watch a film together. And by 7th, 8th day, I'm back on track. Now, this is not depression. This was a transient cross-sectional setback which gave me some difficulties but did not impair my functions drastically or my functionality drastically, is what one needs to understand. But if I had depression, it would have continued for several weeks, at least 2. It would have been pervasive, sustained, continuous, and would have impaired my functions, which is my relationships, my work or studies, whatever I do, my social functioning. So when functioning gets impaired is your red flag.
Right.
And how do you know that you have depression? So, I had this 40-year-old man who comes to me and says that, I'm feeling very sad. And for the past several weeks, I don't feel happy about anything. And my question was that things you used to enjoy earlier. So he said that, I used to love watching cricket. And this is when the IPL was going on. So are you watching it? No, actually last year I was watching all matches, but this year I just don't feel like it. I just switched off and don't see. So was not able to experience pleasure in activities that he was otherwise getting pleasure. And then I'm not able to sleep. Appetite is not there. I don't feel like going to work. Sometimes I don't even feel like getting out of the bed. And this has been happening for a month and a half. Now you look at the signs of depression: sadness of mood, loss of interest, feeling dull, negative, hopelessness, that it's not going to be better, helplessness, nobody can help me, worthlessness, I don't feel good about myself, sleep, appetite changes, irritability or extreme withdrawal, life is not worth living kind of thoughts happening, concentration, focus affecting my relationships, affecting my work, affecting the way I look at myself, may give me self-harming thoughts. That's depression. It continues for 2 weeks or around, starting to impair my functionality. Now this is the profile of the illness, and this could range from an 8-9-year-old to a person 70-80 plus.
The opposite of depression is not happiness. The opposite of depression is actually vitality. Usually the response is, go, take a run, go to the gym. Does that help?
No, it doesn't help. It doesn't help because the moment you are telling this individual that do this or do that and your depression would go away, one, what you are saying is scientifically incorrect. Because if it is depression, which is a clinical form of an illness, it's almost like telling somebody who's having diabetes that, well, don't go to a doctor, just start doing these 2-3 things, your diabetes will go away. Or somebody who's had tuberculosis, don't take the medications, don't go to a doctor, do this and it'll be okay. Start walking, start reading some good books and it'll go away. Similarly, it's not going to go away. So factually, it's incorrect. But the other aspect is that you're actually feeding into the stigma by being judgmental, because what you didn't realize, you are telling this individual, this is because of you. Had you had the sense to take morning walks and do these breathing exercises and eat right food and meeting your friends, you probably wouldn't have got this, and that's not correct. So what it does is, an individual who's already depressed, which is already making the person feel negative about his or her own self, when that person is told you aren't good enough, you are not doing enough to get out of it, it makes the person feel worse, which will also make this individual actually bottle up further, reduce the chances of help seeking, reduce the chances of this individual going and talking to somebody, because one would fear being judged.
And you end up feeling guilty about it.
Yes.
Yeah.
And depression is not something that has come to you by your choice. It's an illness. You don't choose illnesses. It happened to you. It's a statistical number. So if there are 5 of us sitting in this room, and if depression happens in 1 in 5 people, one of us 5 will have depression this year.
Yeah, depression is not your fault. We are reiterating this. Depression is very much like having typhoid.
Yes.
You've got to fix it. You've got to go and seek help.
You've got to fix it. And fixing it will have various levels. Yes, talking to friends and trying to look at what you all can do and how you utilize your support system and how your support system stands up with you makes a huge impact. But if medications are required, well, they are required and there is no substitute for that. Which is not to say that all people with clinical depression will require medication. But those who need medications will not recover in absence of medication is also a fact. And we cannot allow our stigma, our judgmentalism about mental health issues to deny those people who could live a completely fantastic, uninterrupted life had they taken treatment for that short period in time. That cannot be allowed.
Doc, I feel the word mental health itself is very limiting, and it's almost like it adds to the stigma.
We're not very responsible when it comes to our public narratives. from using words which can belittle others, like body shaming, like various aspects of mental illness, like trying to minimize or belittle, use words in a comical way, in reality television, in stand-up comedians, in the entertainment industry, in films. I mean, mental illness and mental health has not really been portrayed in a very sensitive and responsible manner. And what that does is, it has an impact. You must understand. And I have always believed that people should have absolute liberty of expressing themselves and their creativity in whichever way they want. But anything which is in the public domain cannot be done without social responsibility. Creativity and social responsibility trounces creativity. If I, in a creative way, wants to make fun of somebody who's suffering from, let's say, depression, and I feel it's my right to do that, and that results into lots of people who are feeling depressed, do not take treatment, do not take meds, maybe even do self-harm, then this creative expression at the cost of people's life is not justifiable.
We do need to change the narrative, but what is also important, the point that you've brought in, is not everyone experiences depression in the same way, and not everyone has to have the same intervention. One size does not fit all.
If you should get a medication, you should take it. If the doctor feels, your therapist feels that psychotherapy is good enough, that's fine. That's an intervention. Let's also here understand that psychotherapy, pharmacotherapy are both scientific, evidence-based interventions.
Yes.
Equally important, and we don't need to, they are not opposite sides in a football match, they're the same team. And I'm saying this here is because for as many number of people who come to us who have a hesitation about taking meds, there are a lot many more who are okay taking meds but not taking therapy. That also needs to be understood, where they feel, oh, they'll just talk to me. I talk to my friends, I talk to my family.
I don't need therapy.
I don't need therapy.
Yeah.
I'm okay taking meds. So the way there is myth around meds and stigma around meds and people don't take it, one needs to understand that I feel, and over the years in my practice, that there are more people who actually say no for therapy than who say no for meds after they've reached us. Probably because once you've reached the doctor, so half the battle has been won there against the illness and you are more prepared. Probably one of the reasons. But a lot of times when I refer patients for therapy, they say, no, I have enough people to talk to. I don't think talking would help. How can just merely talking help? And we think that, and because conventionally, traditionally, it's called as the talking cure. So you almost think it's like talking. So it's not like you're having a cup of tea with a friend. It's a scientific, evidence-based, guideline-oriented therapeutic process which follows principles, and that's how intervention happens. And I think this is very important to understand that.
Yeah, which is objective and which is non-judgmental, and this is
scientific
and very scientific. But the important thing also to bring out is the difference between a psychiatrist and a psychologist. And there is always this confusion. A psychiatrist like yourself who is able to medicate, and a psychologist who you go to therapy for. Right? This is a very important distinction, and people need to understand. Sometimes you may require one or the other, sometimes you may require both.
That's absolutely true. Psychiatrists are medical experts who prescribe medications. Psychologists, psychotherapists, clinical psychologists, counselors, family therapists, marriage therapists, sports psychologists, oncopsychologists, various subfields I'm talking about are people who use psychotherapeutic techniques, which is the talking techniques. And there are several schools of thoughts and in several styles of therapy. So different people are experts in different kinds of therapies which are used in different kinds of clinical conditions, like how there are various kinds of medications which are used in different kind of for patient profiles. It's that similar. And one needs to understand that whom you go to, frankly, doesn't matter as long as you go to someone. Because that individual, that expert you've gone to, would ideally know that should you be only with them or should you be with somebody else or both. It doesn't matter if you are not sure whether you want to go to a psychiatrist or a psychologist. Just go to an expert without hesitation, somebody who's most accessible to you.
Did you say accessible? Because, the feedback that one gets is that doctors like yourself, I mean, you are accessible. I don't think most doctors are.
No, when I meant accessible, I meant geography.
I have heard stories where there has been misdiagnosis, there has been a lot of judgment. I think patients have the right to question and seek a second opinion.
I completely agree to it. But I agree to it in the context of any field, not merely mental health.
Yeah, true.
Not merely healthcare, in any field. Any expert of any field will never get 100 on 100.
Sure.
Any person who seeks intervention or help absolutely, unhesitantly has a right to be able to explore other options, and frankly I encourage it, right? Because if you feel that you have a doubt or you would want to explore more, I'd rather encourage you to do that. And the fact is, I might have missed something and somebody else will might notice that also. I mean, we are all humans at the end of the day, and that's why my bit on this is, I do not believe that one expert is better than the other. I fundamentally do not believe that there is the so-called star or a star doctor and a star expert, I don't believe in that. And I don't believe because I think that would again deter people from seeking help. It's like saying that, there are top 50 colleges in the country or top 50 schools. I don't completely look at it like that. And maybe when it comes to something like that field, well, because of infrastructural reasons and other factors, there might be some differences. But this is a branch where, all psychiatrists like me have gone through the same exam, read the same books, have almost the same experience. Some would have more, some would have less based on where they've practiced. And in a country like ours, where there is a serious deficit of experts, the right approach, which I've always been advising people, is go to the person most accessible, because fact of the matter is it's not going to be a one-off visit. So if you are living a few hundred miles away from me and you have somebody half a kilometer from your home, go to that person. Yeah. You don't drive several hundred miles because you have this doctor who lives in urban India and who probably you might have read about or something. That's not going to make him or her better. It's the same
because
thing.
Because protocols are the same.
Protocols are the same. It's a science.
This is an important point really, because I think people are running after a few doctors. They want to be seen by those doctors.
And like I said, I say this in my public discourse, I tell this to my patients as well. You go to the nearest person. That's the right approach.
Well, not everybody will believe that, but it's a good thing that you are actually saying that the protocols are the same, and that's an important point really to bring. I have to ask you about the triggers, because I know of somebody who was extremely stressed at work and was unable to balance her kids and work and travel and everything, and she sought help. I know of somebody who had a child and was depressed. I also know of people who were cutting themselves because of depression. I know of somebody who was diagnosed with a terminal illness and was depressed. What are the triggers?
So in your question also lies an answer, that you were able to look at several different kinds of triggers for the same illness.
Different triggers for the same illness.
So for a lot of times, we believe it was the trigger, whereas it could have been the predisposition of the chemical imbalance. And of course, the trigger exaggerated or precipitated those symptoms because of the biological vulnerability that was there. And both things need to be understood. To give you an example, let's say you have a family of 8 people. and let's say they go through a major crisis, let's say death of an individual, or let's say some other major crisis.
Financial loss.
Financial loss, yes. In today's time, in the practice that I have seen, that employment, unemployment, financial loss, appraisals at work, the financial pressures, I think they give more stress than any other form of stress that one can imagine, because it's a new Maslow's pyramid in a way, that if your biological needs are the most basic ones, but how do you afford your biological needs if you are not financially secure? Something which we need to appreciate.
It's a reflection of our times also.
Yes, absolutely. So what happens is, all 8 of them will not react in the same manner.
True.
So the trigger is same, but 8 different people might respond in 8 different ways. And 1 or 2 of them might well end up having a clinical episode of depression as well. But 6 others may not. And that's the biopsychosocial model that I was talking about, that there are various forms of factors which are having a play here. No doubt that we need to work on finding a solution to the trigger. There is no doubt about it, which is why psychotherapy also happens. But only looking at those triggers as being the key or the sole causative agent of depression would not be the right approach.
In a majority of cases, triggers are not the reason for depression. It's your predisposition that puts you
And
at
the
risk.
triggers interface.
And the triggers.
And the social,
Yes.
so the biopsychosocial. So what support systems you had, how were you able to deal with that, what personality you have, what are the cognitive processes that you use, what is your belief system and your behavioral pattern, what are your other resources, what is the emotional makeup and support that you have, what's your biology and genetic pool. That's what would eventually decide.
I'll come back to how 2 different people react to having typhoid.
Yes, you and I could have had the same street food. One of us had loose stomach, the other did not. So it's not only the food.
Right. If it goes untreated, what can depression lead to?
In more often than not, symptoms will worsen, which means you'll feel a lot worse. So if your sadness was this much, it became this much. So you'll feel a lot worse, which means it will also cause further impairment, which means initially if you were going late at work, it may result into pure absenteeism, it may result into not going to work at all. You may withdraw a lot from the society. Initially you were withdrawing from some people, eventually you end up withdrawing from the closest. It drastically affects your physical health, because your diet, your appetite, your sleep, your physical activity gets impaired. Self-harm is something that needs to be seriously linked and understood with untreated depression. If you look at the percentages and statistics around suicide, one would realize that the largest number of people whom we lose to suicide are people who were suffering from depression, and most of them were either untreated, partially treated, and that's what depression does.
Teenage suicide, very, very high in India. The rates of suicide, even amongst adults, is extremely high. Males are more prone to attempted suicide. But you're saying that a majority, I'm not saying all, majority of cases have to do with prolonged depression.
So yes, you look at 100 people who die of suicide, you're looking at almost 90 of them having some form of a psychiatric disorder or mental illness. And the largest chunk there, almost 3/4 of that, would be depression. So yes, depression is very closely related to suicide, and depression is not a matter of choice. Depression is a medical illness, and suicide is 100% preventable, which is why it's so important to collectively focus on suicide prevention. Suicides are 100% preventable. Depression is treatable, and depression you don't get to choose. I have been speaking about this. I fundamentally believe in this, that we need to have a national suicide prevention policy. We need to have a concentrated effort which is sustained over the next couple of decades into suicide prevention, with a focus on adolescent suicide prevention.
Right.
And all of us need to work on this. Losing a young person's life to suicide is probably the saddest experience which the family and the near ones can never come out of. And if you look at it in that way, especially when you see it in the context of results and exams and the performance pressure, what can be more important than a young person's life?
You know, on one hand, there is something that the government can do. That's one side. But we as citizens have a responsibility, right? If we have friends that we think are depressed, we need to get out and try and be with them. Listening is very, very important. And I think this is very important for even family members to hear. When you feel that a person is depressed, you've got to push that person to seek intervention, go to a doctor. Again, your friend has typhoid, you take him to a doctor.
Listen, be around, double check, non-judgmental, non-critical, non-hostile.
I was reading somewhere, ask them whether they are having suicidal thoughts. It decreases chances of them actually attempting suicide. So ask them if they are feeling suicidal. Important here.
Looking at suicide prevention, we need to look at various aspects. Government level, yes, I think we should have a national suicide prevention policy. I think public-private partnership should be there. I feel private healthcare providers need to contribute to mental health, given that predominant mental health providers are in the private setup. So I think all of us we just have to do this, and there's no other way to look at it. Second component here, I think, is media. I think a sensitive portrayal of mental ailments is very important, and I think that a bit of care needs to be taken. Third is the reporting and the reportage of suicide. I think there also media needs to become a lot more aware about how do you talk about it. In that report, you should even mention all the suicide helplines that you know are available in that part of the world. We need a lot more of crisis helplines available in local languages as well. Then comes our role as family and friends.
The difference between depression, grief, sadness.
So sadness is something that we all will experience throughout our life, like how we'll experience happiness and anger. These are emotions. Grief, most of us will experience at some time or the other in our life when we'll have a significant loss. Most of us will come out of our grief within a span of time. Some people, when it becomes prolonged or causes more disability and fulfills the criteria of depression, then it is depression. Then you don't say it's grief, then it is depression.
Depression and manic depression, which is often referred to as bipolar.
A patient of depression essentially has episodes of depression.
Right.
Now, whether it's a one-off episode, whether these episodes become more recurrent in a few years, but all episodes are of depression. That's your depression patient. In bipolar disorder, so bipoles, which means two poles.
Extremes.
Yeah. So in these patients, you have two kinds of episodes. Episodes which are like your depressed episodes, exactly the way a depression happens.
Right.
And some of their episodes are manic episodes, which is
Extreme highs.
opposite pole of depression. In that, you'll feel ecstatic, grandiose, over-energetic, not needing sleep, still feeling energy, doing more activity, seeking more pleasure, very disinhibited, can even get aggressive, equally causing a lot of disability, very difficult to handle.
Risk-seeking behavior.
Yes, because pleasure and risk-seeking behavior drastically increasing. These are the two poles, and these patients sometimes have a depressive episode, sometimes a manic episode. That's why it's called the bipolar. So the two poles, bipolar illness. Bipolar disorder requires medical intervention absolutely for almost everybody.
But in your experience, have you noticed that a lot of people don't even realize that they suffer from bipolar, so they need to...
But the fact is that most people do not realize that they have a mental illness per se. So whether we are looking at depression, bipolar disorder, schizophrenia, OCD, PTSD, the list will go on. Sometimes when they realize it's a problem, but they don't realize that problem is actually an illness and not merely something that we don't know what is happening kind of experience, or we are in denial, or we still, because the stigma and the misinformation, don't want to seek help.
We've been on Zen-Brain talking about ACEs, that is adverse childhood experiences. Do experiences like exposure to violence at a very, very early age, any form of abuse, abandonment, perhaps a loss that you have not been able to process in your mind, do all that predispose you to depression?
Early experiences, traumatic experiences may predispose you to a lot of things, including depression is the right way to look at it.
Sure.
So if you've had traumatic experiences, you are more predisposed into having a PTSD or a post-traumatic stress disorder. Nature of violence you've been exposed to may decide on what kind of impact it may have. The nature of those stresses, the duration of that stress, the support systems you had, so many other factors around it. It is those things that need to be looked into when we look at any form of trauma for that matter, irrespective of the age group.
Thank you very much, Dr. Parikh, for your time.
Thank you.